Hi, my name is John Faragon, and I'm a pharmacist with Albany Medical Center Hospital, and I'm the Regional Pharmacy Director for the Northeast Caribbean AIDS Education and Training Center. I'd like to welcome you here today for this brief mini module. The AATC this year, we've decided to create short little clips of certain topics that are related to HIV, and this first one that we've done today for you is called HIV When to Treat for 2017. So thank you very much for viewing this on our website. So first thing I think we should talk really quickly about is just what happens if you don't treat HIV infection. And this is some older data that was published back in the mid-90s looking at the course of untreated HIV infection. And so just to orient you to the slide, the greenish colored lines is the HIV RNA, and then the CD4 count or the CD4 T lymphocyte count is actually listed in that bluish color line that you can see on the slide. And so basically what this shows you is what happens when patients get HIV infected. If you don't treat them, obviously their plasma viral load depicted in the green line will rise rapidly, and then eventually they'll reach some kind of a set point. And you can see in the middle of the graph, you can see where there's kind of this set point. And then CD4 cells at the same time will drop pretty dramatically when that viral load comes up. And then over time, that dark blue line, you can see it basically falls and continues to fall until you get to like the last maybe 10 to 12 years of a person's lifespan with untreated HIV infection, where you can see the CD4 count drop off. And so when the CD4 count falls less than 200 from untreated HIV infection, that's when patients become at risk for all of the opportunistic infections that we don't see very frequently now because we have good treatment, but untreated HIV infection, we still see those opportunistic infections occurring, and patients do go on to not only have HIV infection, but actually go on to develop AIDS. And that's obviously a big concern and something that we can obviously prevent with the treatment of HIV infection today with the medications that we have. And this just gives you a sense of the different opportunistic infections based on different CD4 counts. So you see at 250, it's oral candida, PCP, PJP, and histoplasmosis is more common around 200. And as you go down, as your CD4 count falls lower and lower, you become at risk for other things such as cryptococcal meningitis, toxo, CMV, and Mycobacterium avium complex. So the bottom line, what I want you to understand is that we're treating patients with HIV infection, and when we should treat them is really the focus of this. But I want everybody to understand that if you don't treat patients with HIV infection, they will eventually go on to develop all these opportunistic infections, and eventually one of these OIs will cause their death, and that's how patients died years ago without treatment. This next slide is kind of complex, but I just want to walk you through it really quickly. And all this really tells you is that basically there's a high likelihood of developing AIDS within 3 years after HIV infection if you have a higher viral load and a lower CD4 count. So if you look at patients on the bottom part of the axis, if you look at patients with greater than 30,000 viral load, and the back bar, the light blue in the back, which is 85.8%, those are patients with CD4 counts less than 200. You can see clearly that the lower your CD4 count and the higher your viral load, the higher the risk of you developing AIDS within 3 years. So the point with this is basically, again, with untreated HIV infection, if you have high viral loads and low CD4 counts at baseline, your likelihood of developing AIDS pretty rapidly is higher, versus those patients who have low viral loads and higher CD4 count, their risk of developing AIDS within 3 years is lower. But make sure you understand that really clearly there's a correlation between how high your viral load is and how rapidly you're gonna destroy T cells, and how rapidly you will develop an AIDS-defining illness, and then if you don't get treated, obviously death. But because of what we have in the United States, we have good treatment, but we still have new patients being infected, and this is the rates of HIV infection, or the rates of adults and adolescents living with HIV infection through 2013. There's a similar slide out for 2014, but the data hasn't changed that much recently. And so the bottom line with this slide, all I want you to look at is the states where you potentially may be living in the United States and what your rates are per 100,000 people. That's what the numbers are that are listed for each state. And you can see that the darker colors, the darker the purple, the higher the rates of HIV infection in that state. And so you can see the worst case scenario in the United States is actually DC, and you can see it's about 2,700 per 100,000 patients have HIV infection in the DC area. In New York State, it's 784. Florida is 606. Texas is 345. California 376. So the bottom line is the darker the color, the worse it is, and the higher the rates of HIV infection are in those individual states. This next slide I'd like to show too, just as kind of a background for why we're treating and when to treat, and that there is a lifetime risk estimate that's out there for HIV infection. So a lot of people ask this, what's your risk of getting HIV infection overall in the general population? And overall in the United States, it's about a 1% lifetime risk. In the bottom left-hand corner, you can see overall in the USA, 1 in 99 roughly will develop HIV infection. However, there are different demographics where you have to really be concerned about the potential risk of HIV. First of all, black men having sex with men, it's actually 1 in 2. So you almost have a 50% chance. If you're a man having sex with men and you're black in the US, you have about a 50% chance overall lifetime risk of developing HIV infection. Hispanics, 1 in 4, and then the white men having sex with men, it's about 1 in 10. So the bottom line, a lot of the epidemic, and I think everybody should be aware of this, a lot of the epidemic is still driven by the men having sex with men population. It's still the largest percentage of people who are newly infected. Hopefully with pre-exposure prophylaxis and other interventions, we're hopefully making a difference with that. However, this slide, I think on the right-hand side, you can see the states. And again, depending on which state you're living in, the darker the color, the higher your risk is for developing HIV infection in those individual states. And not to get into some of the way medications are delved out, but oftentimes in the South, you'll find that those are the places where sometimes there are waiting lists for ADAP. The poverty levels are set differently, and sometimes access to antiretroviral therapy, even though we're living in the U.S., sometimes in the South you'll see spots where the access to antiretrovirals is actually not as good as what you would see in other parts of the country. So again, not picking on the South, because we still have the same numbers in New York and in New Jersey, etc. But just know that part of this whole issue of having a lifetime risk also is related to the number of infections that are found inside that individual state. So the state response to HIV certainly makes a big difference. Not only just the federal, but also the state response makes a big difference. And so this is just a case. I'll just really go through this quick. It's a 28-year-old African male. This was actually based on a case that we had at our clinic. Men having sex with men, multiple partners in the past, now with the same person for 6 months, and the partner is HIV negative. So the baseline viral load was roughly 185,000 copies, CD4 of 185, recent ER visits for STDs and treated with ceftriaxone and azithromycin. RPR, which is our test for syphilis, was negative. Hepatitis C negative. Hepatitis B, he was vaccinated. Uses over-the-counter antacids and H2RAs on occasion. So the question that comes up a lot of times with these new patients is, do we treat them, yes or no? And how do we make that decision? And we'll walk through some of the data that supports that in the next couple of slides. So probably the most important study that actually shaped our decision on when to treat patients is the SMART study. So the SMART study was basically taking a look at comparing pulse therapy, on and off therapy versus continuous therapy. So in the red, you can see this is the drug conservation or the treatment interruption arm. And basically treatment was stopped when their CD4 count fell or rose to greater than 350 cells, and then it was restarted when their CD4 counts fell to less than 250. So basically it was a thought that possibly there might be a way for us to conserve treatment and also conserve costs actually in different parts of the world, and even in the US potentially, if we did this pulse therapy, putting them on and off therapy based on a CD4 count. And they compared that to the same number of patients, 1-to-1, about 2,700 patients in each arm. In the green bar, you can see the virally suppressed arm, which means these are patients that got continuous antiretroviral therapy. They were never stopped or started. So basically, it's asking the question of starting and stopping therapy versus continuous therapy. Does that make a difference from an outcome standpoint? And basically what they showed, this is actually HIV disease progression or death over time. And you can see that the virologic suppression group, which is the continuous group, had a lower percentage of patients with HIV disease progression or death compared to those people in the red bars, which is the discontinuation or drug conservation group, the people who did starting and stopping. And this looked out to 44 months, and it was shown to be statistically significant. And there were some things that happened in the study that people didn't expect. They really thought that the drug conservation group was going to do just as well as the virologic suppression group, and that obviously did not happen. Now you have to remember, all these patients, right, even the patients in the virologic suppression group had decent CD4 counts, so they're all out of the AIDS range, meaning that they have less than. None of these people really had T cells less than 200, because the post-therapy people wouldn't let them fall to less than 250 without restarting, and the virologic suppression group continued to get therapy throughout the entire regimen. So has nothing to do with CD4 count. It really has to do with this whole idea of virologic inflammation. Basically, when patients are not virologically suppressed and they have virus running through their body, they're going to have inflammatory responses and going to have potential progression, HIV progression, and also death. All right, so that was kind of the SMART study. So I didn't spend a lot of time on SMART, but there's other things like, for example, cancers were worse. The risk of renal disease, hepatic disease, cardiovascular disease, all those events were much more common in those patients that did that starting and stopping versus the people that did continuous. So the next question that really came up, we knew about the 250 number from the SMART study. The START study actually did a similar study looking at this cutoff of 350 and 500. So basically all the patients in this study had to have T cells greater than 500, and they randomized people to either get immediate antiretroviral therapy or defer until their CD4 count fell to less than 350. So really we're answering that question about what about CD4 counts of 350 that are a little bit higher and 500, what do you do with those patients? Is it the same outcomes as those patients in the previous SMART study? In the primary composite endpoint was serious AIDS or death from AIDS, serious non-AIDS events and deaths not attributable to AIDS, which included cardiovascular disease, end-stage renal disease, liver decompensation, and non-AIDS defining cancers. And very similar to what we saw in the START study, the SMART study showed very similar numbers, where the number of serious AIDS, serious non-AIDS events were much higher in those patients who actually were in the deferred arm, which is kind of in these blue bars here, versus those patients that are in the immediate therapy arm, which is in the red. So again, two studies showing very similar very similar study designs showing very similar results, where basically keeping people on continuous therapy is really the most important piece. And I think this really kind of informed us that we really should have pretty much everybody on antiretroviral therapy. And this is another one. This is an old one. This has been shown over the years. This has been looked at in other places as well. But this is looking at the whole idea of a community viral load. And this is looking at newly diagnosed HIV cases in the yellow in the San Francisco Department of Health from 2004 to 2008. Again, it's older data, but it still informs us, I think. And then the viral load, which is in the purple in that same clinic. And you can kind of see this trend line where you look at the number of new diagnoses for HIV as those went down from 2004 to 2008, the mean viral load in that clinic also went down. So this whole idea of from a public health perspective of having a lower community viral load will potentially reduce your number of new HIV infections, I think is an important part of this whole idea of HIV prevention and treatment as prevention to prevent new infections from HIV. And finally, I'll just spend a few minutes on the HPTN study. This is the 052 study. These were stable, healthy, serodiscordant couples, sexually active, CD4 count 350 to 500, randomized to either delayed antiretroviral therapy or immediate antiretroviral therapy. And again, looking at virologically linked transmission events. So there were primary clinical events too, but the real most important piece of this is that the question is, if you had people suppressed in the immediate antiretroviral therapy, meaning that everybody would get treatment, what's the percentage of people who are in that subset of patients who are potentially having sex or using drugs? What's the risk of virologically transmitting the virus from one person to another one if those patients got immediate therapy versus delaying their treatment? And what this showed us very nicely, I think, is that there were a total of 39 HIV positive transmissions during this entire study. Again, a very low rate, but what it showed you is that the vast majority of those transmissions occurred in the deferred ART arm. So if you look at the 27 transmissions in those people who did this kind of deferred, where they waited to get treated, versus the people who took therapy right away, there was only one transmission. So what they showed in this study was that there was a 96% protection for people to be on antiretroviral therapy to prevent new transmissions of HIV. And so from a public health perspective, when we're thinking about HIV and thinking about how patients get HIV, we need to have as many patients as we have who are diagnosed on therapy as soon as we can. And really, some of this has even led to these test and treat programs where people are tested, and if they're identified as HIV infected, they're started on therapy as soon as possible, sometimes the same day in some clinics, sometimes even within the first couple of weeks. That's better than waiting 3 months to treat people, but getting people on therapy as soon as possible is really the hallmark of what we're trying to do for HIV. But it also informs us to say that patients who do have HIV infection, once they get suppressed, we need to keep them there. We need to do whatever we need to do to make sure that they continue to take their meds on a regular basis to make sure that they remain suppressed from a virologic standpoint. And so finally, this is the last slide on when to treat. Just the bottom line is really all HIV-infected patients really should be on antiretroviral therapy. This is the DHHS guidelines, basically to reduce the risk of disease progression. But I think also important, and hopefully it's highlighted in some of the slides that I showed you in the last few minutes, is that ART is also recommended for HIV individuals to diminish the risk of HIV transmission. And I think that's an important part. All right, so in the last maybe 10 or 15 minutes or so, we've talked about when to treat. We talked a little bit about some of the demographics of HIV, and we talked about some of the studies that inform the current guideline recommendations for treating everybody who has HIV infection. So hopefully you'll have an opportunity to view this and other mini modules that we have on the website, and I appreciate your time today. Thank you very much.